Good evening, one and all. I am Professor Dr. Veeramani from Moderator College, Madurai, and our today's topic is I am the moderator, and today's topic is going to be discussed by Dr. Raghu. He is the IAE president, current IAE president, and director, non-invasive labs, Care Hospitals, Banjara Hills, Hyderabad, and the presentation will be the case-based presentation in pulmonary embolism. This is the regarding the speaker, and regarding the topic. Topic proper is pulmonary embolism, which is nothing but an embolus in the pulmonary vascular tree in various places and causing various problems. What is the importance in pulmonary embolism? 50,000 deaths per year happen due to pulmonary embolism, and significant proportion of cases of pulmonary embolism remain undiagnosed due to varied presentations, lack of access to appropriate diagnostic testing. So estimated incidence is doubled after the use of CT pulmonary angio. How echocardiography is going to be helpful for the diagnosis of acute pulmonary embolism, we are going to discuss in this next few minutes. And prior to that, the primary pulmonary embolism is an underlying hypercoagulable state will be there, precipitated by a stressor such as prolonged immobilization, oral contraceptives, pregnancy, hormone replacement therapy. The risks of venous thromboembolism among patients with medical illnesses, including cancer, CCF, or COPD. Secondary pulmonary embolism is nothing but due to various types of surgery, like orthopedic surgery of hip and knee, gynecological cancer, major trauma, and craniotomy for brain tumor. These are all the various causes. What is the importance in it? Because most of the cases present as an acute case. It's a sudden onset of chest pain, hypotension, hypoxemia, and distended neck veins. With these features, if we find out the patient, we can diagnosis of pulmonary embolism is very much common, and a differential diagnosis of acute MI and tension pneumothorax, pericardial tamponade. These are conditions we can differentiate with echocardiography. And what is the role of echocardiography? It's mostly, in most of the cases, there will be normal echo, but an excellent tool for risk stratification and prognostication, the echocardiography is useful. Whenever there is a chances of a differential diagnosis of acute pericardial tamponade, RV infarction, and aortic dissection, the echocardiography is very much useful, and the pulmonary artery systolic pressure measurement is also useful. These are all the various things we are going to discuss in the next few minutes by Dr. Raghu. Over to Dr. Raghu, sir.
Thank you, Dr. Veeramani. Thank you, the organizers, for having these webinars. I think this is the last of the Medinet presentations. Over the next 40 odd minutes, I hope to be able to show you how echo can be useful in both, as Dr. Veeramani suggested, both in helping in the diagnosis and to a very great deal in risk stratification and in prognostication. I'll start off with a few examples which we have had in the past few years, and after that I'll take you through the slides which will show you why echo today is in its vantage position in this field. Now, my first case is a 23-year-old lady, a resident of one of the close by districts of Hyderabad, namely Warangal. She graduated from a business school, and her main presentation was with complaints of shortness of breath on exertion for the last 10 months prior to being seen as. She also had chest discomfort on exertion for 4 months. With that, she presented to a local hospital about 10 months ago with history of fever, cough, and disease. There she was treated as a community-acquired pneumonia and hospitalized for 9 days. After her discharge, her fever and cough subsided, but the exertional breathlessness persisted and steadily increased in severity. While she was initially able to do her regular activities, she found that later her activities were restricted because of her breathlessness. She also gave a history of tightness in the chest on exertion, along with her shortness of breath. There was no history of orthopnea or EAD. In fact, she was never breathless at rest. Her breathlessness varied from class to class 3. She had no pedal edema, palpitations, restless stomach. She also gave a history of recurrent multiple joint pains, especially the small joints of the hand. And some of these episodes were also associated with swelling of the joints. But there was no history of alopecia, photosensitivity, recurrent oral ulcers, or abdominal pain. With all this, she went to another hospital where she underwent. Obviously, went to a rheumatologist because of her joint pains, and there further evaluation was done, where they found that she was positive for the ANA and anti-double standard DNA. The ANA profile was done, which was positive for NRNP, smooth muscle, SSA, and SSP profiles, and beta 2 glycoprotein. IgM was also positive. So, in view of these precursors for venous thromboembolism, the consulting physician there must have obviously thought that there is likelihood that she is possibly having current CE. And she underwent a CT chest with contrast, which showed a right atrial thrombus and right pulmonary artery thrombus, and a diagnosis of chronic PTE was made. She was also diagnosed to have mixed connective tissue disease with secondary APLA, that is antiphospholipid antibodies, and chronic PTE with a large RA clot, and started on hydroxychloroquine and oral anticoagulation with levodoxaban. During a follow-up in the OPD, she was having lower back pain and persistent recreational breathlessness. Steroids were continued, and dabigatran which was started was changed to Flexi. She underwent the NECO, which showed a large heterogeneity in the RA attached to the RA free wall, just below the tricuspid valve. This was the initial impression was, could it be a thrombus or it was a myxoma? There was no RV outflow obstruction, and the right ventricular systolic pressure was only 36 millimeters. CT chest with contrast was done, which showed obstruction of the distal RPA with non-opacification of the branches due to chronic P. Pulmonary infarcts in the periphery of the right lower lobe, a dilated RARP, and an MP, and right atrial thrombus were also noted. The right superior and inferior pulmonary veins were thought to be smaller in caliber because of a decreased RPA flow. Bilateral lower limb Doppler was negative for them. She also underwent whole PET CT here after she was admitted with us. Some might question why was this done, and this is the case of a pulmonary thromboembolism. Well, I'll come to that. That was a physician's choice in our institute. We want to be, after I show the echo pictures, I'll discuss to you about this. I'll just go directly. So the impression was a mixed connective tissue disorder with secondary APLA and a chronic pulmonary thromboembolism, the RA and RCA thrombus. She had exertional hypoxemia. The TE showed a PFO with the right left shunt, but her had normal resting PA pressures. Now, this was the ECG. As often happens in thromboembolism, the ECG is quite often not very contributory. Many studies have shown that the typical ECG findings of de-invasions in the anterior leads of S123P3 is seen in less than about 20% of the patients. So in this case, the ECG is hardly contributory, possibly because there's no evidence of pH on the echo. The XHS also was not very contributory. There's a slightly rotated film, so the impression that you get of a pulmonary artery being rather prominent is possibly fallacious, as you can see that the film is markedly rotated. Now, this was what was first seen when we did the echo, and that showed that the right ventricle is contracting well. And if you notice, the right ventricle also is not very dilated and is contracting well. You see a small mass, what look like small mass at least in the transthoracic echocardiogram, possibly attached to the tricuspid valve, tricuspid annulus. But in this thing, we could not be very sure where exactly it was attached. The CT pictures were not very clear as to where the attachment of the mass was. So the mass itself was, at least in transthoracic echo, echo didn't seem very mobile. Now, this was the transesophageal picture at the 0 degrees level. And you can see a large mass attached to the lateral wall and not collapsing out of the tricuspid valve. The important characteristics which I would like you to note is that this is one of the things that echo helps in diagnosis, is that you notice here a central area of lucency. Now, this is what is called the central clearing. That is often very diagnostic of thrombi within the heart chamber. This happens because normally when a thrombus forms, part of it also undergoes lysis. And the outside clot is the freshest, whereas the inside clot is the slightly oldest part of the thrombus. So that area tends to be partially lysed while new clot is forming around it. So this kind of echolucency within a muff, while it can happen in neoplasms also because of necrosis, is often very, very useful to suggest that this could be a mass, the thrombus rather than a tumor. Right. So this is the 120 degrees angle, which the transitional plane, which shows the mass. Now you can see very clearly the mass is attached to the lateral wall of the right atrium. Now we did a contrast study. You might ask me why, but this is something that we regularly do in our laboratory. And this patient had also complained of some amount of lightheadedness and all that. So when we saw the mass and we were wondering whether small emboli had gone into cerebral circulation also. So the contrast was done, and you can see very clearly that there is intermittent opacification of the LA and the LV with saline contrast. It's a very small shunt, but that is enough to suggest that there is always a possibility that this patient not only can have a pulmonary embolism, but can also have a paradoxical cerebral embolism from a mass within the right atrium. Now, the right-sided echo TE shows what we normally do in such situations. So wherever we suspect a pulmonary embolism, I'll come to that again later also. What you see here is the SVC. And as you see here in the biplane, you find that you can see the main pulmonary artery very clearly, and also the right pulmonary artery. The left pulmonary artery, unfortunately, is covered by the hyparterial bronchus on the left side. So we don't see beyond the origin of the left pulmonary artery. So what you see here is that the pulmonary artery is quite clear in the main pulmonary artery and the proximal part of the right pulmonary artery. So these are the CT pictures that shows the large mass in the right atrium. And it doesn't give us any clue as to what it is due to. And as you can see, you can just see that it's an oblated mass. But as I mentioned earlier, unlike from the transesophageal echo, you cannot really say where exactly it is arising from. You also see the pulmonary artery now coming into focus, and you see that the right pulmonary artery branches are getting cut off. So the whole body PET was done mainly to rule out cancer in this patient and paraneoplastic syndrome. At that time, because of the large RA mass, we were considering the possibility of sending her for surgery, and that's why the physician thought best to have a PET scan just to rule out any metabolic neoplastic lesion. This, of course, was proved negative. And these are the PET CT scans, which shows no uptake of FTG near the heart or in any of the abdominal or lung fields. So how did we manage this patient? This patient, we had a team discussion of the cardiologist, the physician, and the CT surgeons. The thrombolytic therapy was not considered at all because of large mass and the fear of its breaking down and danger of further embolism. After multiple discussions with the patient and the caregivers, she finally consented to surgery. She was quite vehement that she did not want to undergo it, but we finally convinced her after showing her the recordings of the transesophageal echo and telling her the dangers of recurrent pulmonary embolism. So high-risk consent was taken, and the right atrial mass was removed, and the right pulmonary artery thrombectomy was done. She had an uneventful course, and discharged after a week. She has been put on lifelong anticoagulation with DKA. So we'll move on to the next case. This is another interesting problem that I had quite recently. This was a 59 years male, hypertensive. He was non-diabetic and he was a smoker. He was evaluated by me in 2015 for recurrent chest pain. At that time, his ECG showed EP inversions. And because of the ECG pattern and this history, since he was not willing to undergo further stress testing, I took him up for a coronary angiogram, which revealed that he had a normal coronary. His echo at that time was normal. There was no evidence of hypertrophic cardiomyopathy to explain the key inversions. He presented in October 2020 again with symptoms similar to atypical chest pain for 3 to 4 days duration. On questioning, he admitted that he had a transient fever a week earlier, but it was just lasted a day and he did not give any importance to it. Then he started developing significant shortness of breath on mild depression, but there was no history of PN. Clinical examination was quite unremarkable. His JVP was normal. His BP at that time was 130/90, and the SpO2 was 97. His ECG showed the same changes as in 2015, so I was convinced that there was no cardiac problem again. And his blood workup was quite normal. Now, this was the echo that was done. I'm showing you the short axis window view. Shows a slightly dilated RB, as is also seen in the apical fourth chamber view. There is no septal flattening. And as you notice, the RV function is quite good. You can notice that the RV is contracting right from base to the apex, and it's squeezing quite well. There was no TR significant MR, and he had at best a mild TR. This is just to show you that his IVC was quite normal. It was not dilated. Now, this is what we got from the Doppler signals. His pulmonary velocities are quite narrow, and the acceleration time was somewhere between 60 and 70, suggesting that he is having mild moderate pulmonary hypertension. His mitral velocities do not show much more than an altered LV compliance, so there's no evidence of a diastolic dysfunction responsible for PAH. And his TR velocity showed an RV systolic pressure varying from about 45 to 50, depending on how much you want to add as the RA pressure to the TR velocity. Now, if you see the right ventricular TAPS V, that is the TAPS CS, as some people label it, the systolic annular velocity of the right ventricular free wall, it is more than 10, suggesting that the right ventricular conductivity is quite good. But definitely, if you see the basal and mid measurements of the RV does seem dilated. Now, pulmonary embolism was the least of my thought process at that particular point of time, and I thought maybe I was dealing with AST, which was possibly missed in the previous evaluation in 5 years earlier. Now, the next day morning, I took him up for a trans-ECG echo because the thought uppermost in my mind at that particular point of time was whether I'm missing out AST because the RA-RV were dilated. The pulmonary pressures were not very high, and I thought maybe I'm because he was an obese person and the window was not particularly good. I thought I couldn't get a good subcostal window, so I wasn't very confident that I had not excluded an AST. So this shows a moderate TR, and I've already shown you that the PA pressures were about between 45 and 50. And when we did a contrast study, the IAS was intact with a PFO. You can see the septum here bulging there. You can see the septum bulging with small PFO. There was trivial flow across the IAS, and there was a scanty movement of contrast from the right atrium to the left atrium. So at least we could rule out an AST at this juncture. And moving on, it's generally my policy always to look at the pulmonary artery when I do a T. And when I looked at the pulmonary artery, what you can see is very clearly a distinct labeled layered pulmonary RPA plot. And this can be seen very clearly in this is the aorta. This is the right pulmonary artery. I showed you earlier in the previous thing how the pulmonary artery can be made out in T. And very clearly you see the right pulmonary artery and the clot here, both by 3D and by 2D. So obviously now the diagnosis has completely shifted. I was dealing with a patient who was had practically no risk factors at all for pulmonary thromboembolism. Nevertheless, if you see his Geneva score and all that, his score was practically in the range of 1 or 2. He had really no comorbidities, and there was no reason, there was no issue of DVT in the past, there was no venous edema or anything of the sort. So it was quite surprising. Now, when I did a CT the same day, I found that he had a clot both in the LPA, and this is the layered clot stretching into the left pulmonary artery. And if you see the CT here, this was what I could pick up by the transcendental echo. This was the clot which is seen in the contrast CT of the right pulmonary artery. And here is another cut showing the same clot in the right pulmonary artery. So with this, diagnosis of pulmonary embolism was made, but I was not really sure why he had it. He was hemodynamically stable, quite comfortable at rest, though he was, of course, having some dyspnea on exertion. His SpO2 at rest was quite normal. So I sent him for further workup and advised him to get admitted for treatment. He found it the financial constraints of being admitted in our center, and he preferred to go to a government hospital. Unfortunately, when he landed there, they refused to admit him because that particular hospital did not entertain COVID patients. And this patient was thought to be COVID positive because of what they felt was ground glass opacities in the seat. So he next went to another hospital where they hospitalized him. And over the next 2 days, his workup showed that his D-dimer, IL-6 were all elevated, CRP was elevated. And his D-dimer came in the range of some 4,300. I didn't have the report. These are all oral communications made by the doctor concerned. And he was COVID positive. So in this setting, they tried to manage him conservatively. But over the next 2 days, this patient deteriorated, his saturation started dropping. And the physician concerned in collaboration with the cardiologist started him on thrombolytic therapy with articulate, and his condition stabilized and he was discharged. In the last follow-up, he was doing well. His pulmonary pressures had normalized. So did not get a follow-up CT because the echo showed some regression of the right ventricular dilatation. His right ventricle is normal, and the PA pressures were normal. So this is an example of how difficult it is when you're not thinking. If you think that something is likely, then you will easily pick it up. But it's not always possible, either in the emergency or in the outpatient setup, to regard every patient who comes with shortness of breath to be likely to be because of pulmonary embolism. That's why I will subsequently outline that there are many scores or available to us to see whether they fit into the high probability or low probability. However, this patient, by either well score or the Geneva score, would not fit into a probable. He would have fitted in the lower probability scores. Now, my third case is another interesting problem. This 25-year-old lady, she delivered 15 days prior to admission with us. She developed shock due to postpartum hemorrhage and renal shutdown. She was transferred to our institution in the next 24 hours. And she was started on hemodialysis via perm cath based in a tubular vein. Her condition stabilized and she was being planned for discharge when she developed small amounts of scanty hemoptysis and some atypical chest pain. Her X-ray and ECG were normal. She was referred to us for an echo, and this was what we saw. You see again lobulated mass with some central clearing, and this mass seems to be attached very close to the SPC. It's not very clear from the TE where exactly the attachment is. But as you can see again here, there is no evidence of right ventricular dilatation. There is hardly any TR, but I had to do a contrast study to get the TR, and that showed a normal pressure. Our IVC, as you can see here, was also normal. It was not dilated. So to get a better delineation of the mass, this is in another off-axis view to see whether we can pick up where the attachment to the mass was. Unfortunately, the mass seemed to be floating though it was obviously it was attached, but we couldn't make out where it was attached. Now, this was the TE that was done, and that very clearly showed that the mass was attached to the lateral wall of the was coming from the SVC, not to the lateral wall. And here, if you notice, there is a structure here which though you don't see the clear tram line, it suggests that the perm cath is the place from which the mass is coming into the right atrium. This we have seen quite frequently in quite a few patients where perm cath is often responsible for masses, sometimes infected masses too. So this lady immediately had to pull out the catheter. Luckily, there was no further embolism. The perm cath was shifted to the another venous access. The old perm cath was removed. She was anticoagulated for a few days and then was discharged in a stable condition. Luckily, she improved, her AKI improved, and showed off dialysis in a month of her discharge. Moving on, this is another very interesting patient. This is a 60-year-old gentleman. He is a butcher by occupation. At the time of our first consultation, he was seemed a very well-to-do businessman who was involved in meat industry. But he told me that there was times in the past where he was even actively involved in butchering and all that. He had no comorbidities, but he had undergone a permanent pacemaker implantation for sick sinus syndrome 5 years prior to his first presentation. Now, he had a prolonged history of intermittent fever, with chills lasting for just a few days each time. He had consulted multiple practitioners. This happened over a period of 1 to 2 years. And he had consulted multiple practitioners and treated various antibiotics. An echo done elsewhere during one of these episodes was also reported as normal. He never had symptoms of shortness of breath or chest pain. He was admitted to our institution with history of fever of a few days duration. Again, this was another episode of fever. His CBP showed a mild neutrophilic leukocytosis and a slightly raised ESR. Other biochemical parameters were normal. A D-dimer was not done at that particular point in time, but a collagen profile workup was normal, and so was an abdominal ultrasound. Now, this was the first echo that I recorded, and this I like to accept with all humility that I actually gave it as an echo with no serious abnormalities, except that I thought I saw a lead. Later, after the full diagnosis was when I went back and checked this echo, I thought maybe that because of the poor window here, the right side is not very well visualized, unlike the left side. He was a thin, tall person, and getting a subcostal window was beyond the was beyond. And this, while we could see the lead in the RV, the lead in the LRA was not very clearly defined. And there was a suggestion of a mass here which I could not be very sure about. At that particular point in time, I do not know. Maybe I thought it was an artifact, but nevertheless, I'm willing to accept that I gave this as a normal report at that particular point in time. Now, what happened subsequently was something very interesting. The clinician came and talked to me and said, Dr. Raghu, I know you've given a normal report, and I have great respect for your findings, but I feel strongly that we should do a team. He was so persistent that I did not say no. I could not say no, and I'm till today I'm very grateful to him for compelling me, because when we did a TE, this is what we saw. This was a huge mass attached to the pacemaker lead in the RA. Now, you'll see it better in this view. There you can see the mass in the 120 view. You can see the mass encompassing the completely encircling the lead. And so obviously now it's obvious that this was the mass that was responding for his symptoms of recurrent fever and all. Now with this, we decided that it's time that he should have the lead extracted so that he doesn't have recurrent pulmonary embolism. He, despite repeated advice to going for operative intervention, patient kept refusing. He was discharged after a course of antibiotic, which was given empirically, as repeat blood cultures after and before the diagnosis were normal. 6 months after the initial presentation, he had another episode of fever. This time he had chest pain and hemoptysis. A repeat echo and he showed no change in the mass. It had neither grown in size or nor had it shrunken in size. A CT angio was reported as subsegmental pulmonary embolism with consolidation, and he was again treated with antibiotics and anticoagulants and discharged with the recommendation to undergo deep and mass extraction. He finally changed his mind and underwent operation and removal at another hospital. This mass was sent for histopathology and was confirmed as a thrombus. Now, what came as a big shock was when we got the report, none of us had heard that there was an organism like this. It was called Erysipelotrix cruciopathy. Now, we went and spoke to our microbiology professor, and she said that it's a very, very rare organism, and it often gets infected in humans who come in contact with animals or with, as his profession as a butcher, maybe he had constant contact with meat or meat, and the soil, the water contaminated with soil, and must have had the entry of the organism to one of the cuts or bruises that he may have suffered. So this is just to tell you that in all these cases, the pretest probability was possibly very, very low, and yet echo helped us in making a diagnosis of pulmonary embolism. So how does where does echo stand today? Is there a PE? Is it diagnostic? How severe is the PE? Is it prognostic? Now, as Dr. Veeramani already said, CT has now completely taken over the role of diagnosis of pulmonary embolism. So, given the ubiquity, that is, its availability almost everywhere, when can echocardiography really help? So, because now, if you think of a case of pulmonary embolism, you readily will go in and do a CT. Then where does echo come in? Now, in a setting like ours, in a country like ours, I agree that all the Mofussil towns and all the major cities have CT scans spread all over their places. But even now, in the smaller towns, I'm sure Dr. Veeramani will agree because he's in a major city and he's surrounded by a lot of well-developed towns. The availability of CT is again not as common as an echocardiogram. I mean, echocardiography machine. So, in our country, stands as a very important aspect on the approach to a patient with a suspected pulmonary embolism. Also, even in good centers, this was a study which was published in which they said that in more than 3% of the patients who come to the emergency department, the CT was not feasible because of various reasons. And this percentage is possibly far higher, to the tune of even 15%, where a patient admitted in an ICU may not be suitable to be sent to a CT department. So, how does echocardiography here? This algorithm will help us to some extent. If you suspect an acute PE, if the patient is stable to move, then you use the clinical probability scores. And if it's low, a D-dimer is done. And if it is negative, you evaluate for another diagnosis. If it is positive or if the pretest probability is high or intermediate, you go in for, and the D-dimer is positive, you go in for a CT angiogram. If it is negative, again, you evaluate for another diagnosis. For patients unstable to move, what do you do? a bedside TT is possibly the best option, along with, say, lower limb Doppler, including a compression ultrasound and such other things. And if it is normal, and if the troponin or the BNP or TT is abnormal, then we start a treatment for the. Now, as Dr. Veeramani mentioned in his introduction, basically what is more important in these situations is more than ruling in or ruling out a diagnosis of PE. Echo is very, very useful in ruling out all those conditions which can mimic pulmonary embolism, namely tamponade, pulmonary arterial hypertension due to other reasons like even COPD or primary pulmonary hypertension, valve problem like aortic stenosis or severe mitral stenosis, congenital heart disease, heart failure because of other reasons as well as dysfunction. Right ventricular myocardial infarction is particularly very great mimic of pulmonary embolism, and dissection can present with hypertension, suggesting that with a suggestion that might be because of pulmonary embolism, and an echo, if it picks up a dissection, can easily rule out pulmonary embolism as the cause. Now, look at this CT. This is I've included to show you that CT gets the entire pulmonary anatomy beautifully, and that is one of its greatest attributes. So if you have a CT, nothing like that to diagnose, and then the role of echocardiography is reversed. But if you see the echocardiography, you can get some ideas, as I have shown in 2 of my cases. You can look at the pulmonary artery, as you can see in these images. This is the pulmonary artery branching to the right and the left, and you can use various views, even as suprasternal notch view to see the pulmonary artery. And if you angulate the transducer side, you can even see the bifurcation of the right pulmonary artery and left pulmonary artery. In fact, I must tell you that I have a couple of times picked up pulmonary artery thrombi in the right pulmonary artery from a suprasternal view. But this will happen in a very small percentage of patients, even with people known case of PA thrombus, because the window in an adult is not always very easy to get from a suprasternal notch view. So I have shown you for 2 cases where there is right heart thrombus, and so the diagnosis of PE was made from echo also. But how often does transthoracic echo really help in picking up right heart thrombi? In the ICOPA study, they found that there was only a 4% only 4% of people right ventricular thrombus was detected by TT in patients with pulmonary embolism. So it's rare. I'm sorry if I gave you the impression that because 2 of my patients had that most PE patients have. Actually, they don't. Very few of them have, and this was brought out very well in the study, which showed that only 4% of the right heart PE patients had right heart thrombus. So then, how does echo help? Certainly not in primary diagnosing, but it helps in deciphering PE etiology. Suppose you see a mass in, I've already said, CT does not help in characterizing or determining the etiology. An echo can easily differentiate a mass as a as a myxoma or a thrombus or even a metastatic mass like a sarcoma. Also, the character of the thrombus, if it's a long thrombus which reflects the cast of the deep veins, one can easily come to a conclusion that the mass is from the veins, or it's a IVC mass or an HVC mass. Non-venous entities can also be diagnosed, like infective endocarditis. Sometimes if you have an addict, you can have a large vegetation in the tricuspid wall that can also produce pulmonary embolism. Myxomas, papillary fibroelastoma, sarcomas. In fact, this patient, the previous slide I showed, was actually a sarcoma in one of the patients. Now, this is another case, just to show you. This patient had pulmonary embolism. You can see the RV being flattened, the RV hyperkinesia, and also the dilated RV, the LV being normal. What you see here is a thrombus which is very clearly attached to the interatrial septum. Now, we did a TE for him, and TE showed multiple thrombi, but one of them is actually a thrombus that is attached to the interlated septum. And when we did a contrast study, we had a PFO, so there was a part of thrombus was spreading into the left atrium also. In other words, this was a thrombus in transit. And if you see the later part of the recording, I have shown very clearly that this patient had pulmonary artery thrombus. You can see this very clearly in the right pulmonary artery. In transesophageal echo, if you pull the probe to the mid-esophageal level, come to 30 degrees and rotate the probe so that you see the main pulmonary artery, and if you rotate it a little further and pull it out a little, you can see the right pulmonary artery quite well. And as I mentioned, you don't see the left pulmonary artery at all because of the bronchus and the air trapped in it. So diagnosing PE by echocardiography, the sensitivity is very low. Most studies have given the sensitivity as less than 50%. And what we do is often infer from draw an inference that it could be pulmonary embolism by surrogate markers of pulmonary embolism. That is either the right ventricular diastolic volume or the right ventricular thrombus or ER, right ventricular hypokinesia. All these are unfortunately confounded by chronicity. I'll explain that in detail later. And but of course, it is most useful for the differential diagnosis of any masses and can give you some idea about it. So actually the ACC in fact says that it's inappropriate to use echo for establishing the diagnosis of PE. This is quite shocking because, as I said, in our country, echo is easily available. Unlike in the West, echo is very cheap. And so I would, without hesitation, any patient, whether suspected or any patient who comes with breathlessness, I would most certainly continue to use echo, whether whatever the guidelines say. But of course, the ACC guidelines have taken into account the fact, like I mentioned earlier, that the sensitivity of echo is very poor, and because in them they have to justify the use of any investigation depending upon the yield it gives the diagnosis. They have mentioned it as very appropriate. What they label appropriate is when you have a known acute PE to guide therapy, example for thrombectomy and thrombolytics. Now, this chart shows that I'll try to explain where exactly echo becomes very useful. Now, if you see this pyramid, the high risk is at the top. High risk are those patients who've had a cardiac arrest, cardiogenic shock, or vasopressor requirement for more than 30 minutes. If they have they're a little lower risk, even patients who have acute respiratory failure and hypertension are the high risk. Then you have the intermediate risk where they are normotensive, but imaging shows that there is right ventricular strain and elevated cardiac biomarkers, either that or this. Or in the intermediate low risk category, there is evidence of either right ventricular strain or elevated biomarkers, and the low risk is where everything is normal. Now, when you're given this kind of a setup, then there is a suspected pulmonary embolism, and you remove the high risk category altogether. Then you calculate the PACE score. PACE score is the pulmonary embolism severity index, and if that is significant, then you either do see an echo. If the echo is abnormal, then you label them as intermediate risk, depending on whether the troponin is positive or BNP is raised. Now, if this is the case, then echo helps in categorizing. See, suppose this patient were labeled as intermediate low risk, but echo suggests that this patient, because of RV dilatation, RV dysfunction, and raised pulmonary pressure, will be shifted to the intermediate risk. And on follow, if the patient's condition is dictating, echo will subsequently help in shifting the high risk and thereby changing his modality of his treatment. Now, what else does echo do? Echo, of course, gives you the size of the RV, LV, the relative sizes of RV, LV, IVC, and PA. But more important, what echo does is it gives you the RV systolic function. And as I mentioned earlier, it gives you the right heart pressures and also the McConnell sign. Now, if you see these three pictures, you will see that the RA is dilated, the RV is normal here. Here the septum is flattened, and here you can see that the RV is dilated, the apex is contracting, and the base and the thing is not hardly contracting. It's what is called the independent sign. Now I'll come in more tell you more in more detail about the sensitivity and specificity of it. But in comparison, CT can give you only measures. What it does not do is give you the systolic function of the RV. It does not tell you the right heart pressures, and it does not show you the maternal sign. At best, it can or may not give you the septal geometry. So CT beyond diagnosis is not as relevant as echo is in both measuring the demands of treatment or the prognosis of a patient. Now, if you look at this chart, the sensitivity and specificity of PE relate to clinical deterioration. Now, if you see this chart, when you have right ventricular strain on CT and right ventricular, but it is negative on TT, out of the 25 patients, 4 patients had the event. Whereas if the right ventricular strain on CT is again negative on echo, the event rate is only 3%. So TT does not predict the prognosis as well as echo does. So when you have a positive right ventricular strain on echo, but it's not there on CT, then even then the prediction of events occurring in the next 5 days is much higher by echo. So echo definitely scores in this regard. Now, what is the problem? What problems do we face? Now, as you have seen in my case, in all those cases where there was RV dilatation, the unlike the LV where we do this incidence modality and tell you the exact LV volume, the RV volume or even the fractional area change is not. Most of us still continue to do it by visual assessment, and that is not a very good tool because then because of the unusual geometry of the RV, it's quite possible that many of us get it wrong most of the time. So the other thing that is very useful is what is called the TAPS S or the TAPS B, which is the systolic tissue velocity of the right ventricular free wall. And I'll come to that later. Also, the more easily and more often done, more extensively investigated the tricuspid annular plane systolic excursion, which measures again the in M mode rather than in tissue doctor, the excursion of the tricuspid wall annulus. And this assumes the problem with this is it assumes that this is a though it's a local excursion, it reflects on the global function. Specifically, it may not be true in all the disease states. Now, TAPC has been found to be very useful in acute PE because it is depressed in acute PE, in PH, and in chronic thromboembolic pulmonary hypertension. The major advantage is its negative predictive value. If a TAPC is more than 15 millimeters, the negative predictive value of a pair of patients with pulmonary embolism slipping into a high risk category is very, very low. And if it is the positive predictive value, that is the TAPC is less than 50, prognostication using TAPC is not really very reliable. This chart also shows that this is the curve with the TAPC of less than 15 centimeters, and it doesn't really predict the event rate very accurately. So to summarize, echo in PE can be useful in certain cases based on surrogate diseases. That is the right ventricular strain. Right ventricular strain, the composite term that means the right ventricular dilatation, right ventricular function, reduction, right ventricular systolic function, or even right ventricular hyperkinesia. And of course, it can pick up right heart thrombus. It is much more useful in the sensitivity and specificity in prognosticating the future of the patient and giving a holistic impression of why the patient has had a pulmonary embolism. It is very useful to give a negative predictive value, but its positive predictive value is still being ascertained. It is also very useful in procedural guidance. For example, this was a mask, which under TE guidance was removed by a transcatheter approach. So let us look at some of the articles which give us the Dr. Veeramani, please let me know whenever you want me to cut down on my slides.
Okay, so, sir. You may continue these things and then we go for discussion.
Yeah. So this particular study was very impressive. They did a systematic meta-analysis and of all the trials. I'll show you in the subsequent slide what they have done. what they concluded that studies show a consistently high specificity and a low sensitivity for echocardiography in the diagnosis of PE, making it potentially adequate as a routine test at the bedside in critical case settings, as the emergency department and intensive care unit for patients with suspicion of PE, especially those unable to get other confirmatory studies. Future research may continue to clarify the role of bedside echocardiography in conjunction with other tests and imaging in the overall management of pulmonary embolism. This was published in the Journal of American Society of Echocardiography in 2017. And this is what they did. They searched PubMed and other databases and found that 7,164 articles in their searches. Out of that, 1,200 were duplicates and were removed. Of the 5,900 odd articles, they found 5,441 were titles were deemed irrelevant and so were excluded. So finally, out of the 466 articles for a full review, 443 did not meet their criteria for inclusion because they possibly the diagnosis was not obvious or the amount of clinical data or the echocardiographic data was not enough. So potentially they had only finally 22 articles included in this meta-analysis. And what they found was, again, what I've been mentioning in my talk so far, that some of the signs have a very high specificity. If you notice, all of them, like hypokinesia, McConnell sign, RV strain, TAPSI, they all have specificities in the range of 90 to 95, of which, of course, right heart thrombus and McConnell sign had the highest specificity. But look at this abysmal sensitivity. They all follow below the 40. The only sensitive sign was thought to be right ventricular end-diastolic diameter, especially with the end-diastolic diameter is more than 3 or 3.5. Unfortunately, what they mention is that there are no clear-cut guidelines as to what the right ventricular. In different trials, they've used different values as accepting as and increasing RV end-diastolic diameter. Now, of the 22 articles, the probability of disease in all these studies was high at 40%. So they were preferentially looking at articles which were dealing only with pulmonary embolism. And that studies consistently showed high specificity for echo, with none of the signs lower than 80%. Most of them were in the range of 85 to 95. However, sensitivity was very, very low. Meta-analysis confirmed that echo cannot rule in, but not rule out. P can rule in, but not rule out. The RV end-diastolic diameter appeared to have the highest sensitivity. Can serial echo studies improve diastolic accuracy? This was not answered by any of the papers. Echocardiography has been confirmed to be a robust predictor of mortality, and this is its greatest tool. It prognosticates, and the 30-day event rate by all those signs that I've shown helps in understanding what the future could be in a patient with a pulmonary embolism. They also did a very nice subgroup analysis in which they compared the echo studies that were done in the lab and in the emergency department and focus studies at the bedside. And they found that they all yielded similar results. So that's a very heartening point to suggest that whenever a patient with dyspnea comes into the emergency department, an immediate echo study will go a long way. Another point that they raised was, will combining deep vein and long ultrasound improve accuracy? That is a point that has to be taken up in the future. Now, this was another very interesting study, very good analysis. This echocardiographic pattern of acute pulmonary embolism, analysis of 511 constitutive patients, again in the Journal of American Society. Their methods was a single center retrospective analysis of over 511 patients. And they concluded that transthoracic echocardiography showed no significant abnormalities of PE in 71% of the patients of diagnosed PE, while in approximately 10%, transthoracic echocardiography also revealed incidental findings. The coexistence of an enlarged hypokinetic right ventricle with McConnell sign together with the 60-60 sign seems to be the most useful echocardiographic criteria. Now, the 60-60 sign was something I showed in one of my patients, the second case, I think, where if you have a acceleration, pulmonary acceleration time of less than 60 and an RV systolic pressure of less than 60, normally, if you take a primary pulmonary hypertension, the RV acceleration time of less than 60 would mean a PA pressure of more than 80. But in pulmonary embolism, because the RV does not support high pulmonary artery pressures, generally in an acute pulmonary embolism, the RV systolic pressure rarely is above 50 or 60. So this 60-60 sign has been shown to be very valuable, very specific, and unfortunately not very sensitive. So again, this table will tell you how among all the signs, the McConnell sign again, the right heart thrombus and the flattened IVS and the acceleration time are all the most sensitive specific parameters. But the sensitivity, if you see, is pretty low. Incidentally, these are all the various things that they look for in patients of flu. Now, this very important thing, again, this graph shows you what I've been mentioning, that the sensitivities of these signs was pretty low and the specificity was very high. But look at this box chart. This is very important in your understanding echo in pulmonary embolism. Now, what they found was in all the 406 patients with non-high risk pulmonary thromboembolism, and with negative RV strain, they found that the incidental findings of other conditions, like say left heart disease, mitral stenosis, maybe 9.1%. And even in patients with one of the typical signs, echocardiographic signs, was present, the incidence was 4.8. So what they argue is one of the problems with echocardiography in pulmonary embolism is sometimes it can mislead you, because if there are other incidental findings like say severe aortic stenosis or severe aortic regurgitation or wall motion abnormality, then you tend to echocardiogram tends to take you away from the suspicion of pulmonary embolism, and this is something that we always need to keep in mind. So they mentioned that RV enlargement are where the most frequent abnormalities. Less pronounced signs of RV overload were observed in nearly 46% of the patients. And TES, that is typical echocardiographic signs, was present only in 20%, 16%, the 60-60. 71% of the patients, TT provided no clues at all. So a combination of all three signs was pretty useful and very specific for pulmonary embolism. Now, this is another study which mentioned practically the same thing, but they went one step ahead and did RV strain also. And they found that there was no significant RV global strain and hospital stay or mortality. Now, they tried to compare the RV strain. This is a patient of normal RV strain. And here's a patient of pulmonary thromboembolism where the RV strain is reduced. Here, the average strain is about 10, and here the average strain is about 27 or so. And they found that it was not correlating. However, in another study, which used both acute pulmonary three-dimensional echo and spectral tracking, they concluded that acute submassive pulmonary embolism has a significant impact on RV function, as assessed by 3D echo and spectral tracking. Decreases in the mid-free wall RV longitudinal strain and 3D EF may persist during short and long-term follow-up and correlate with unfavorable outcomes. So what they have shown was very interesting. They showed that the RV strain not only is decreased during acute pulmonary embolism, but if the patient recovers at the time of discharge, which quite a few patients do recover once the treatment has been done, it certainly gives a much better prognosis because the event rate is much lower. This schematic diagram from the ESC guidelines, the lovely schematic diagrams. Anyone who's dealing with emergency medicine or cardiology should have this ESC guidelines downloaded, which is a very composite treatise on the subject. This shows one of the signs is the enlarged right ventricle. Another one is the dilated RV and the RV to LV comparison, which is more than 1. And you can see the McConnell sign. Here you see the septal flattening and the distended inferior vena cava, which only goes in favor of the RV dysfunction. This is the 60-60 sign that I mentioned. And what is very typical in the 60-60 sign is the notch that you see in the early systolic period. And there was one article in JACE which suggested that this notch can be a very, very important diagnostic tool. But there was an editorial which said that it is too early to suggest anything of that sort. Then, of course, the mobile thrombus and a decrease in the diameter discussion and a decreased peak systolic velocity on the tissue Doppler and right ventricular wall. So these are the various findings to put in a nutshell in a schematic diagram, which anyone who does an echo in a suspected case should perform. Now, I'll go to one last case, and this is 36-year-old lady, mother of 2 children, who was diagnosed to have DVT in the past with irregular anticoagulation. She developed acute shortness of breath, cough, and chest pain 4 days prior to admission. She was admitted to another hospital where CT reported as bilateral segmental embolism. She was started on warfarin and discharged. At admission, she was comfortable with a resting saturation of 94%. She had anemia, and her INR was 1.8. There was no history of melena or hematosis. And later we diagnosed high-intensity anemia. She was hemodynamically stable. Her blood biochemistry was normal, and the collagen profile was normal. However, she was APLA positive. Her condition improved after 2 units of fracture transfusion. While on heparin, she became increasingly dyspneic and desaturated. She was thrombolized with tenectomies. Elsewhere, she was this was the echo when we did when she started deteriorating, and it shows that this was the initial echo, and it showed a very severe PA. But all the classic signs of pulmonary thromboembolism are there in this the flattening of the septum, the dilatation of the RB, and of course the RB free wall hypokinesia. Now, when we looked at the pulmonary artery, look how much the pulmonary artery is dilated. We see a distinct thrombus here with some mobile element. And her pulmonary artery diastolic pressures were fairly high, and the systolic pressures were in the range of 91 millimeters. So we thought that despite the fact that she had earlier the recurrent DVT, we thought that we are probably dealing with an acute or chronic pulmonary embolism. And we because the condition deteriorated, we went in for thrombolysis. Repeat echo showed persistent pH, but the values had come down significantly to 60. Right ventricular dilatation persisted, the function itself improved. She was offered surgical embolectomy before discharge, but she refused. She was discharged on Visolone and warfarin. She continues to be on regular follow-up. She continues to have pulmonary hypertension, but is able to do her routine domestic chores and is only mildly symptomatic. Now, this is a meta-analysis of 15 trials and 27,000 patients. It shows that the incidence of recurrence of pulmonary of venous thromboembolism is highest in the first few weeks or even up to the first 2 or 3 months. So this should always be taken into account with more periodic follow-up. The natural history of chronic thromboembolic pulmonary hypertension is that it occurs generally when you have an acute PE. 96 to 98% of the patients completely resolve. It's only in a small number of patients who go into CTEPH. And the problem is, once you wait for a long period, small visual changes keeps developing going on. And that's why, if any intervention has to be done, it should be done very early, at least within 3 months. This chart shows the operability assessment by multidisciplinary teams. Technically operable, going for the pulmonary endarterectomy, as in one of our patients. Otherwise, you go in for target medical therapy, and the ultimate, since they greatly respond to the treatment of vasodilators like the primary pulmonary hypertension do, they have to be considered for a lung transplantation. Now, I told you these are all the recommendations. I think, Dr. Veeramani, I will not go into the various recommendations of diagnosis, treatment of pulmonary embolism, because I think I've covered the major aspects of what pulmonary embolism presents as. And since we are running short of time, I think I'll conclude here with the statement that echo is, though not diagnostic in pulmonary embolism, is a very, very useful tool, both in monitoring the patient and in deciding on when to intervene and what is the type of intervention. Thank you very much for all your patience, and I'm open to any questions that you might like to ask.
Very nice lecture, sir. Thank you, sir. Thank you very much, sir. And I am having certain questions, and then followed with, if there are any questions from the audience, they will go put in the chat box, and that questions may be via the audiovisual people we sent to us, and we will discuss it afterwards. First of all, what is the in first case, the 23 years old female, and what is the use of TE, and to find out the attachment and central lucency, the consistency of the mass is very much useful as discussed by you. And what are all the conditions in which the PFO is opening, the status of PSO opening, whether it is adverse source, adverse prognosis in these cases, that has to be told by you, sir. And ECG, whether it is contributing, but in this case, the ECG is non-contributing. So the echo is very much valid. And in pulmonary embolism, what is the echo protocol? If there is any echo protocol which has to be followed, you have to tell, sir. And when to go for pulmonary embolectomy, whether echo is diagnostic in cases for which the embolectomy is, can be done. These are all the things in this case we have to discuss, sir.
As in our lab, we have a very low threshold for transient echo. And when we see a mass, and if you notice that this patient had complained of light-headedness and all that, and I mentioned that we often combine with a contrast, a silent contrast echo. And if we can show that there is a PFO, which in this case, I think I demonstrated, there was a movement of the silent contrast into the LA and LV. You become that much more confident in saying that surgery is an absolute option in this patient. And only with that, we could convince the patient for it. Now, because she was being taken up on the table for her surgery, the surgeon decided that he will try to extract the pulmonary mass also, pulmonary thrombus also, which he was successful. Now, this patient, since she did not have PH, probably did not warrant an extraction. But most patients with CTEPH, like I mentioned, would end up needing an embolectomy. The embolectomy can be surgical, or it can be even as is being done now by balloon pulmonary angioplasty. Now, what was the last question that you mentioned, Dr. Veeramani?
Sir, is there any echo protocol for which has to be followed for pulmonary embolism?
Like I said, experience makes your own protocols. Like any patient with shortness of breath, if there is no obvious reason to believe that there is a left-sided pathology, then you look at the right ventricle, and you look for thrombi, you look for PAH, and all these would possibly point out towards the pulmonary embolism. In fact, about 10-12 years ago, I had one of my relatives who came to the emergency and had a cardiac arrest. Even as she was being revived, her heart started contracting again. They did a quick echo and found that the RV was grossly dilated. They rushed her to a CT and found that the main pulmonary artery in both the right and the left pulmonary artery flipped off. They immediately started on, at that time, what was given was tenecteplase. And she still follows up with me. It is now more than 10 years. Subsequently, we found out that she was on oral contraceptives, which I made us to stop. And then after 1 year, when I tried to stop the anticoagulation, he had another recurrence. So she was now not on oral anticoagulation. So it is possible that there were other factors also. Though we looked for APLA and coagulation profile abnormalities, it was not there. But after the second episode, I maintained her own long-term anticoagulation.
Sir, what is the use of contrast imaging other than to look forward the PFO opening?
Two things. In this case, I forgot to mention in the first case. Sometimes, if it's a vascular sarcoma or other things, when you do a contrast saline, the tumor also gets opacified. But if it is a thrombus, as you saw in that recording, the mass was very clearly, the contrast was not entering the mass, and it was creating a negative contrast effect. So that is one of the things. Beyond generally it is our protocol. We do a lot of contrast studies, especially for our neurological patients, and so it is a habit with us. Sometimes when we are dealing with PH, we do a contrast study to find out whether this patient develops likelihood of developing a future paradoxical embolism.
So especially in nowadays, for the past 1.5 years, we are having cases, so many cases of COVID positive cases with pulmonary embolism in various modalities of presentation. What are all the changes? Is there any treatment method change? And is there any investigating modalities to be add on with the regular echo in these cases?
More than anywhere else, the presence of D-dimer is very confusing. So as you know, D-dimer has a great negative predictive value, but it doesn't have much of a positive predictive value. So if you do say 100 cases of D-dimer positive, we are now routinely giving anticoagulation for all these patients because the pathophysiology of COVID is one of multiple small thrombi in the smaller vessels. But actual large vein thrombosis is not greatly increased from the general population. Of course, there is some increase. So D-dimer may not be very helpful. So you need to have a low threshold to do a CT angio. HR CT is not going to answer your question. So you need to be ready to do pulmonary angio to pick up pulmonary embolism. If, like in this patient that I showed, there is definitely RV dilatation out of proportion to the pulmonary hypertension that we saw.
Especially in emergency room settings, when the patient presented with acute chest pain and hypotension, what are all the things you will look for in the echo? Whether it is...
Sorry, Dr. Veeramani, please.
Okay, sir.
No, basically, at that particular point of time, as I look at it, you look for RV dilatation. You look for whether the cause for sepsis is the heart at all. Now, suppose you're dealing with a patient who's in shock. Their heart is normal. The IVC is normal. You will think in terms of hypovolemic shock. If the LV contractility is abnormal, you will think of myocarditis or some other LV pathology as a reason for the shock. So you can define what is the reason for the shock and the hypotension rather than incriminate pulmonary embolism. So, but if you do a D-dimer in such a setup, the D-dimer is positive, then even if the RV is normal, you need to go in quickly with a CT angio to make sure that you're not dealing with a pulmonary embolism.
Yes, sir. In the most of the cases in pulmonary embolism in acute setting, they will present with the pulseless electrical activity. Pulseless electrical activity may be the presenting findings. In which case, whether it is echo is very much useful.
Well, no. See, if you see the epidemiology, a good 10% of the patients never reach the hospital in massive pulmonary embolism. Now, if they have a pulseless activity, then it's very difficult to diagnose anything until the heart re-establishes.
So, in most of the cases, the echo is very much useful even in the emergency setting. In a submassive pulmonary embolism, the diagnosis will be very much helpful with the echocardiography.
Yes.
So, this is the finding. And the fractional area change, TAPSE and S prime, these are all the common findings, common things we have to look for in these cases. And whether it's a procedural guidance, you have told about the future of the echo in yes, procedural guidance you have told, and RV function parameters, mainly the RV end diastolic dimension, that is a important one. We have to assess the echo criteria for the RV dysfunction. The three echo criteria: hypokinesia of RV and McConnell sign and 60-60 sign. These are all the things Sir has discussed very well. And if there are any questions from the chat box, we can see. Sir, what is the physiology of McConnell sign and why is the apex hyperkinetic?
This is not a very well understood thing. The one is that the major portion of the RV free wall becomes hypokinetic because that is the one which is mainly involved in the pumping function of the right ventricle. Now, like I mentioned, the two studies on strain that they have shown, they gave very contrary results. They showed that in one patient, contrary to what the McConnell sign is, the apex showed a lower strain. Then they implied that because of the LV contractility in the tachycardia, the strain was not properly recorded in the apex. So the exact reason for the McConnell sign is not very clear. It basically, like I said, it's seen only in 20%. In the vast majority of patients, it's more the entire RV free wall which is hyperkinetic. The value of McConnell sign is that it is supposed to be very specific, but there are caveats even for this. It can be seen in other conditions like COPD or severe pulmonary hypertension. Any condition which produces severe pulmonary hypertension.
Yes, sir. Another one case they have that Dr. Jawahar Farooq has told, 80 years old anemia, dyspnea, tachycardia, SaO2 85%, BP is 170, RV dilatation, RV dysfunction in echo, COVID positive, angio left pulmonary artery embolism. How to approach this case?
Can you repeat that, please?
Sir, the 80 years old patient is an anemic and dyspnea, tachycardia is present, SaO2 is 85%, BP is 100/70, RV dysfunction is there, RV dilatation is there, echo COVID positive status is there, and angio left pulmonary artery embolism. How to approach this case?
In this case, Dr. Veeramani, I would put it in the intermediate risk factor, and because there is no hypotension. However, I would possibly go in for a troponin test or a BNP, and they are elevated. Then he would move to an intermediate high risk category, and in such situations, because of the hypoxemia, as happened in our patient, the decision to thrombolize is taken into account. Now, I didn't show you that slide, but in this age of patients, patients who are thrombolized have a higher degree of survival, but at the expense of a higher degree of bleed. So currently, what is being done in such a situation is possibly using catheter-directed thrombolysis. That is, you put a catheter in the left pulmonary artery and the right pulmonary artery. In this case, since it was shown only in the left pulmonary artery, you put a catheter, you give 20 milligrams of TPA over 2 hours, and then continue with heparin, and they tend to do fairly well. The chances of intracranial hemorrhage is much less when you do a catheter-directed thrombolysis.
Yes, sir. Yes, sir. In this type of cases, there are chances of hemorrhage is more. So we have to be catheter-directed thrombolysis will be a better option in this case. And sir, the next question is the difference between the echo findings of acute and chronic pulmonary embolism.
The difference is in acute, like I mentioned, in acute pulmonary embolism, the RV pressure never goes very high. Because the RV in an acute overload situation cannot sustain a cardiac output beyond 50 to 60 millimeters of pulmonary artery pressure. And that is why if the pulmonary artery embolism is massive, the RV fails immediately. And that is the reason why you develop hypotension. I've got slides of the pathophysiology of the RV, but because I was running short of time, I did not bother to go into these slides. But if you see, the initial thing is an RV dilatation, valve insufficiency, increase in wall tension. All this produces a vicious cycle of decreased RV contractility, which leads to a decreased cardiac output, systemic blood pressure drop. Because of this kind of a scenario, your pulmonary pressures are never very high. They cannot go very high beyond 50 to 60, and that is why the 60-60 sign has come into work. I hope I've answered this question.
Yes, sir. Yes, sir. So the next question is, does the completely normal right-sided echo rules out pulmonary embolism?
No, I mentioned very categorically that it can rule in but not rule out. Its sensitivity is very low. So if you have a submassive pulmonary embolism, you may not have an RV that is dilated. Your PA pressures are not elevated. Like in the first case, I showed that the PA pressure was only 36. Of course, he had other signs of pulmonary embolism. But in many cases, you can only rule out pulmonary embolism either by a D-dimer. If you have a negative D-dimer, it has a very high value. In fact, there are trials of D-dimer which they have shown in more than 4,000 patients that if the D-dimer is negative, during follow-up, less than 3% of the patients present with pulmonary embolism again. Whereas a positive D-dimer doesn't have much predictive value, and you still need to go. It only alerts you for the need to go in for the next step of investigation, which is a CT pulmonary angiogram. So a normal echocardiogram does not rule out pulmonary embolism.
So in that case, whether it is a RV strain is useful in when comparing the other signs.
No, RV strain goes along with RV dilatation. We are still in a very, very early stage of this, and I don't think I want to hazard an opinion on this. It is too early to use RV strain and say that because RV strain is abnormal, this is pulmonary embolism. I don't think we have reached that stage.
Yes, sir. How the reliable is the T in predicting the accuracy of pulmonary embolism? What are the views recommended?
No better than the transthoracic. It is slightly better than transthoracic because it can visualize the possible pulmonary artery very clearly. And I have shown in 2 of my patients pulmonary thrombus in the right pulmonary artery. And in 1 patient, even transthoracic showed the entire left pulmonary artery being clogged with the clot. So these are all very rare cases. See, we are in a tertiary institution. Because of the large volume of patients referred with various conditions, we are able to pick up. But if you're in a Mofussil center dealing with echo, you're very unlikely to do a TE in every patient. And so I wouldn't recommend that you do a TE just to rule in a pulmonary embolism. I think it's far better to do a CT if your suspicions are very strong. If your Geneva score suggests that the pretest probability is very high, then you just simply go in for a D-dimer followed by a CT.
How common is pulmonary embolism in COVID patients? And what are all the various presentations you have seen, you come across in these 1.5 years?
I have seen a few cases. I can't say Dr. Veeramani because most of our COVID patients are handled by the physician's team, critical care team. So because of the constraints of entering the ICU these days, we don't do many bedside echoes unless the patient is critically ill.
So the carpulmonary sign in echo.
Sorry, sir?
Carpulmonary sign in echo. In echo, how will you assess the carpulmonary?
Now, one of the most difficult things in by echo is to differentiate carpulmonary from CT pulmonary thromboembolism. Now, I really don't know what the carpulmonary sign is asking me. If you are in a position to answer, Dr. Veeramani, please help me out.
Yeah. Sir, you have elaborately told about the prognostication of pulmonary embolism that some doctor has asked. And what is the percentage of patients with pulmonary embolism and anterior ECG changes? A patient who has had PE, should he be on lifelong anticoagulation? How much should be the INR? These are all the 3 questions they have asked.
One is, I do not know the exact percentage, but I have already mentioned that an abnormal ECG is present only in 15 to 20% of patients of acute pulmonary embolism. And if the pulmonary artery pressures are high, you might get changes of right ventricular strain in V1 to V3, which is expected as T inversions. Now, how much of anticoagulation? If you're using VKA, which is now not the preferred choice, nowadays NOAC is the preferred choice for pulmonary embolism. If you're still using VKA, that is vitamin K dependent anticoagulation, then the INR should be anywhere between 2.5 to 3.
So with these things, we are coming to the near closer. And what are all the endpoints? What are all the take-home message you have given regarding the management of pulmonary embolism as such? And what is the use of echocardiogram? You can put in a nutshell.
Well, I've repeatedly told this over my treatment is guided by all those guiding principles of the American College of Cardiology and also the European Society. But basically, those guidance are only guidelines. Each individual patient will merit a different approach. Like in my first patient, she required removal of the clot, which is not mentioned in any of the guidelines. Now, the second patient was thrombolized because somebody felt that he was becoming more breathless, not because the saturation dropped. So, guidelines are supposed to help you, but basically, what you wish to do is to use echo to diagnose perfectly, confirm it by other modalities, and treat at the earliest. See, if you have an intermediate high risk patient, he requires to be hospitalized. Whereas an intermediate low-risk patient can be put on anticoagulation and even discharged home. A low-risk patient need never be hospitalized. So these are the things that we learned from managing many of these patients. And I've already repeatedly emphasized what are the signs that are very important. They are the right ventricular dilatation, the right ventricular hypokinesia. Look for any thrombi or other masses in the right heart. If you can, look for directly for thrombi in the pulmonary artery, both by transthoracic and by transthoracic echo. Look for the 60-60 sign. Look for McConnell sign. It may not be present in all cases, but an occasional patient can show. I hope I've answered all these.
Sir, excuse me, they have put two questions now in the chat box, sir. RVMI and acute pulmonary embolism, how to differentiate?
Sorry, sir, I didn't get you.
RVMI, right ventricular MI, and acute pulmonary embolism, how to differentiate?
The ECG will be a very useful tool, right?
Yeah,
MI is never seen in isolation. It is always associated with an acute inferior wall MI. The presenting feature will be chest pain, which is the predominant feature. Patient may be hypotensive, but they respond to fluid infusions. And if you take right-sided chest leads, the ST elevation V2, V3 are very classic.
How much number we can add in PA systolic pressure for each degree of RV systolic dysfunction?
I am not aware that you add like that. You add only by the given rule of what is likely to be the RA pressure from the IVC sites.
Okay, sir. There are no more questions, sir. You have answered most of the questions and you have given a valid points and given a nutshell how to use the echocardiography in various modalities of echocardiography for the diagnosis of pulmonary embolism and how echocardiography is useful in prognostication and the use in the treatment and what are all the procedural guidance by the echocardiography in the future. We have discussed elaborately, sir. Thank you for this nice opportunity to the IAE, Dr. Prasad sir, and the other senior IAE members. Thank you, one and all, for the nice opportunity, sir.
Thank you very much, and I thank all the participants for having patiently listened to my talk and taking active participation by asking so many questions. Thank you. I think I'll take leave at this time.